Everybody, welcome to the Kidney Coach YouTube channel. I'm naturopath Fiona Chin, co-founder of the Kidney Disease Solution, Kidney Coaching Cryogenesis, and I'm joined again today by the fabulous and wonderful Dr. Morgan Camp. Dr. Camp is a functional medicine practitioner. He's been working for 20 years now in the functional area, and in fact, I know I've spoken to you, Morgan, numerous times that you were disenchanted with the normal medical model that people are going through and really wanted to make sure you were treating people as a person and not a disease, treating the cause, not the effect. So that took Morgan down the rabbit hole of bioidentical hormones, looking at peptides, energy medicine, consciousness, diet, you name it, he's looked into it. And what I really love about Dr. Camp is he's a walking, living, breathing example of his work. He practices what he preaches. I can't say that about everybody. And it means that he does try everything out on himself, a bit like me, which I love. So today we are going to talk about all things anti-aging, chronic disease, rapamycin, and the mTOR pathway. Dr. Camp, thank you again for joining me and for your time.
Thank you very much, Fiona. Such a pleasure to be here as always. And yeah, I love this topic. It's one of my favorite ones. I gave a similar talk to a group of doctors a year ago. So I do have some slides for that talk, which we can add in today. And right. Yeah, so we'll have a lot of information. We'll cover a lot. And yeah, I'm super excited for this topic.
Awesome. So for anyone listening, most of our people on our channel have kidney disease. So why don't we start really high level? Why are we even discussing this topic? What does this have to do with people with chronic kidney disease?
Yeah, in a nutshell, as kidney disease progresses, the main mechanism is through fibrosis, right? So the kidneys are fibrosing. And that, that's like an inflammatory state. So what is behind inflammatory states? Senescent cells. So what are senescent cells? These are these, quote, zombie cells, which we'll dive into in a bit. And these zombie cells are what release the inflammatory chemicals that fibrose and scar tissue, like those in the kidney. So rapamycin is what we call a senomorphic, meaning it doesn't kill senescent cells, but it slows down the growth of senescent cells. So what rapamycin is really good for is not reversing an illness, but preventing the progression of it. It might have slight reversal in some cases, but and we'll go through how this works, but the main takeaway for rapamycin is you want to start it, around age 40 or so or later, because that's when disease progression via senescent cells typically starts in most people. And yeah, we'll go through how that works and the mechanism of that and such.
Yeah.
But yeah, around age 40, basically you're getting these inflammatory cells called senescent cells that are damaging organs like kidneys. So the damage that's there, from those senescent cells can be reversed in some ways, but not necessarily via rapamycin. So again, and we'll dive into the how and why of that. And there are other treatments, again, that might be more effective if you have a more progressive disease. But again, rapamycin is actually FDA approved for people who have had kidney transplant and who want to avoid organ rejection. So we know it's very safe for the kidneys because many people it was FDA approved in 2009. So at this point, millions of people have taken it every day for many, many years. And they have studies on those populations. And I think one of my slides will show that in those populations, there's a reduction in kidney cancer, I believe, in people who are taking rapamycin for transplants. Yeah.
Yeah. And for anyone that's wondering, I take rapamycin every day for other reasons. But tell me, rapamycin, so most people think of rapamycin if they've come across it as a drug, but it was actually discovered as in the dirt in Easter Island. Have I got that right?
Yes, so it was discovered in 1965 in the soil of Easter Island. Scientists were, I don't know what they were looking for, but they scooped up soil. And then it's a long, fascinating story how it happened, how they discovered it. They basically, some chemists were working for a company, and then they put it in their freezer at work. Then the company went out of business, and then the chemist, like the last second, grabbed that bag out of his freezer. They didn't even discover what they had for 10, 15 years, I don't believe, and I don't remember all the details. But it took a long time for them to discover actually what they had. So it's actually an antifungal from the soil. And it's interesting that an antifungal is at the heart of treating a lot of chronic illnesses here and preventing those, interestingly enough. But yeah, the name Rapa comes from Rapa Nui, which is the native name for Easter Island.
I find that very fascinating. Okay, so we've done a big podcast before on senescence. Anyone that wants to listen to that, and we will dive into that at a high level. But if you want to really get into the nitty-gritty of that, we've got a previous podcast that you can listen to. So talk to me about senescence and zombie cells. Let's just walk people through that a little bit more, because I think, the whole part that if you take senescent cells out of a rat and then put it into a healthy rat, they go and get exactly the same disease. So senescent cells, my understanding, and please correct what I've got wrong, are almost like viral cells, aren't they? How they affect and infect the cells next to them to become these cytokine inflammatory producing cells.
Absolutely. They're like an infection in that, like you said, if you transfer them senescent cells from an older mouse that has a disease to a younger mouse, within a very short period of time, they have the same illnesses, very short period of time. So it's almost like an infection. The term zombie is great because, it fits the description well. They're basically cells that won't die like a zombie. And not only will they not die, but they're damaging to the environment via the cytokines. Those are called SASP, senescent associated secretory phenotypes, which are the cytokines, the harmful chemicals they're creating. Think cytokine storm and COVID. Those are all related terms. Those come from senescent cells, actually. And what else? Where else was I going with that, Fiona?
Kidney disease and how that is important in chronic disease, right through that mechanism.
Yeah, so let me pull this up. I've got a slide.
Yeah, here's some slides if you like.
We'll go through the slide of it to review the basics. So because otherwise I sometimes can jump ahead. So let me not do that. So here we go. Here we go. So these are slides. So senescence. I'll just go over here. So senescence is defined as a state of irreversible proliferative arrest triggered by persistent activation of stress. That stress could be toxins, infectious agents, shear stress, radiation damage, basically anything that's bad for your health that we know, pesticides, chemicals, etc., all induce senescence.
Fascinating.
And so when we have senescence, what happens then is our autophagy, which is our cellular repair mechanisms, stop. So when those stop, then we're not having cellular repair. And so basically we have cells that keep growing. These zombie cells are creating harmful chemicals. They're destroying tissue around us, and the kidneys are destroying the tissue, increasing more fibrosis. And they're stopping the cellular repair process that we have also.
Yeah, which is why kidney disease is so progressive, isn't it? Because it's just those cells that then become fibrotic. Slowly as that tissue decay, like lack of blood flow, not having the autophagy and repairing themselves, and the next sort of cell gets like that, and we get this decline going.
Yeah, it's like, and that's like an avalanche. So what happens? So there is a threshold of senescence above which disease manifests very quickly. So when you have a low amount of senescence, your immune system can clear the cells pretty easily. When you go above that threshold, then all of a sudden the zombies have taken over. They can't be killed, and they've eaten everything, and they're destroying all the tissue, literally, and then disease is happening, and there's not much to do about it at that point. So this
very
is
the last of us, isn't it?
Yeah, exactly. And so this is just a little slide, a reminder, what is autophagy? This is the process of cellular repair. Mostly it's a process of repairing degraded, unwanted proteins. It's how we maintain good cytoplasmic health, cellular homeostasis, and it's super important for mitochondrial health. It's important for the health of all of our immune system cells. These are just the normal repair mechanisms that are ongoing basis in all of our cells. Yeah, so here's the next. Okay, so I'm going in reverse here. So what we want to do here to set the stage for our talk is talk about autophagy, senescence, this process called geroconversion, and then the mTOR. So we'll go through those, then we can have a little better discussion here. So just a little bit more scientific review. So this is just to review a summary of why the senescent cells are so bad for our health. And again, because the main thing is these senescent cells are releasing these SASPs. So SASP are, just think cytokine storm. So these are the cytokines, chemokines, pro-inflammatory chemicals that cause fibrosis and kidney disease. When you have the flu or COVID, it's what makes you feel like you have the flu, that rundown, just feeling all over. Those are cytokines. And remind me later, and we'll go over how these senescent cells are related to COVID and long COVID. Yeah, so that's that. We've already covered the rest of that. All right, here, so what's geroconversion? So geroconversion is when it's basically the process of a healthy cell becoming senescent. So that's called geroconversion. So in this, any cell can become this, including stem cells, including immune system cells. So any and all cells can undergo this process and become senescent. And then the more senescence you have, the sooner you're going to have a major chronic illness.
So interesting, like if people are having, say, stem cell treatments and things like that, if they've not treated the underlying cause, say they've got an acceleration of senescent cells, they could nothing will work in a sense, because like you mentioned, that avalanche is going and the slide is already going down. That really, unless you're doing something to slow that down, which is what we'll get to, anything you pour in on top of that is going to be useless.
Yeah, so you actually could be making it worse.
Yeah, I didn't want to say that. I wasn't sure, but yeah.
And this is something nobody is talking about in medicine. And I wonder why some stem cell treatments work, others don't. Well, got a lot of senescence, and most people getting stem cells have disease, so you probably do have senescent cells. Basically, they're just zombies sitting there waiting for more cells. So if you flood them with healthy cells, the zombies are like, oh, there we go, more to eat.
More people to buy and infect. Yeah, makes sense.
So they just turn those senescent cells, back into, the stem cells into more senescent cells.
Fascinating.
I recommend all my patients, if they're getting stem cells, you take Senolytics first or you take Rapamycin first, and we'll talk about, that and the difference between the two. So to finish the talk, the why are we talking about geroconversion part? So why are we doing that? What does rapamycin do? Well, we think it's slowing down that geroconversion process. So it's slowing down the conversion of healthy cells to senescent cells. So again, if we start this at an early enough age, then we will, in theory, slow down that creation of those senescent cells, which are driving disease.
So can I ask then, is this something, and so rapamycin in a sense is anti-aging or slowing the aging process by preventing this geroconversion. Would you recommend that anybody then take rapamycin as a preventative of chronic disease potentially?
Yeah, absolutely. I think, starting again, you don't need to do this earlier in life, but starting around, age 40 is what science seems to be showing is the time when senescence is, for most people, going to be starting to cross that threshold. So we want to catch before it crosses that threshold. What this is pointing at, Fiona, is a topic that most people haven't really talked about and very few doctors think about. But actually, we think of aging and we think of all these diseases and we think of them all as separate. But in the end, all these chronic diseases everybody have is just aging. It's a manifestation of aging, and it's a manifestation of this mTOR mechanism going haywire, which we'll go into. So I recommend anybody who wants to look at that discussion deeper, they can look at Dr. Alan Green's website. He has a good website. I think it's called Rapamycin Therapy or something like that. He's a doctor in New York. He's an older gentleman who is basically someone came out of retirement to start practicing this medicine. So I've talked to him on a few occasions. He's a good resource for this, and he mostly treats doctors who want this, and he's got a few thousand doctors now I think he's treating. So he's got probably more patients on rapamycin than anybody else. So he's a very good resource. And his website has all the science and all the research, and he also goes into some philosophical questions like we're discussing now, like, are all these illnesses that we get with old age, like atherosclerosis, dementia, Alzheimer's, diabetes, are these separate diseases, or they're all just part of the same process? Well, what science shows is that underneath all these illnesses is an mTOR pathway gone haywire. And we'll talk about what that means and the science behind that here going forward through the rest of the talk.
Perfect. Let's jump into that because people want to know. I just find this so fascinating that we could potentially be giving something that, and I'll let you talk to the side effects and things shortly, with few side effects that could be really preventative for people. I don't think it takes away from eating well and managing stress and exercising and all of that stuff, but we've got this potential preventative thing on hand, and no one, like you said, I know what's talking about it, no one's using it. So keep going. Let's delve into mTOR and the rapamycin studies that you're at. So we'll go to mTOR, but first, like, just the basic science on this. In all species has been tested on yeast, worms, mice. Rapamycin improves longevity, and what they found is the earlier you start it, not in youthful but more like middle age, the better it helps, the longer the lifespan extension is for these animals. There are studies now going on with dogs and humans. So there are several organizations, I believe, who are doing online studies for rapamycin and following people. And this is part of what my long-term goal would be to create create a system where I could have people on, rapamycin, whether they're my patients or just the public who want to be part of a study where we can look, are you taking rapamycin? Do you do saunas? Looking at all the lifestyle components and following people over time, because that's really what you need. Follow people over time and really see what's working. So there are people already doing this now. There are some studies already going online, and Dr. Alan Green has one such study already published, and we'll talk about that a bit later too. But back to the mTOR question. Let's go back down here. I think this is the right slide. Nope, a little further. Here we go. So mTOR, what does mTOR mean? First off, it means mechanism. What is it? Mechanistic treatment of rapamycin, I believe. So rapamycin is actually in the name, that we didn't discover. We didn't discover this pathway, and I think I got that wrong. I think it's jumbled up, but rapamycin's in the name because we didn't even know this pathway just existed until we had rapamycin to block it. So this pathway exists in all organisms, all eukaryote, all organisms above above bacteria. So all animals have it. Almost all plants have it too. So this is pretty much this is pretty much basic to almost all organisms. And it controls basically cellular growth and repair. That's really the main thing it's looking at. And then there's two pathways in mTOR, mTOR1 and mTOR2. There's a little typo there. mTOR1, so when mTOR1 is activated, your cells grow. And when it's inhibited, you have more cellular repair. So it's more like, when it's activated, you're in go mode, growth and expansion. And when it's turned off, you should be more like healing and renewal. mTOR2, we don't know so much about what it does because we don't know of anything that only blocks mTOR2.
Rapamycin at low dose blocks mTOR1, at high dose blocks both. So we don't have anything that only blocks mTOR2. So we don't know exactly everything that does by itself, but we know when it's blocked permanent, you get more insulin resistance, diabetes, and high blood glucose for sure.
Right. So you don't want to be blocking mTOR2 for long.
Yeah, you don't want to do that for long, and we'll get into that. That's what daily rapamycin does. So you take rapamycin daily, you're going to get both blocked. If you take it once a week, you're only going to have an mTOR1 block. That's the idea.
Yeah.
Yeah, so again, here's the summary. Actions of mTOR1. Think of it as anabolic. Anabolic means muscle growing, muscle building, so increased protein synthesis, cellular growth, proliferation, and main thing here, decreased autophagy. That means less cellular repair. If your cells aren't repaired, what are you going to get? You're going to get cancer. You're going to get diseases. Your cells are on haywire.
Right.
So what stimulates mTOR1? So it's very basic, actually. When would your body want to grow? When you got oxygen, when you got amino acids in abundance, and that stimulates mTOR1. When you're under a lot of stress, you should block mTOR1. When you're undergoing autophagy, you block mTOR1. Again, mTOR2 we don't know so much about because we don't have a selective inhibitor for it. mTOR1 is inhibited when in a state where you shouldn't be growing, right? When you have low oxygen, low AMPK. This is another pathway I'm not so familiar with. Low amino acids, which would be like a starvation state. So this is why low-calorie diets are shown to improve longevity in every study.
Yes.
Why? Because it's low protein, low amino acids. It's blocking mTOR1, just
That
like
makes sense. So intermittent fasting is a great way to block your mTOR1 pathway, which makes sense why it's so good for polycystic kidney disease, because polycystic kidney disease we know is a massive overabundance of mTOR1 and 2, especially with the blood glucose and blood pressure that goes with polycystic kidney disease. So so fasting and really low carb diets and things like that work very well, which makes complete sense to me. Absolutely.
So if you really put on your thinking cap when you're going through this, oh wow, that's how that works. That's how this lifestyle factors, And the way I really think about hyperactivation of mTOR1, then this is pretty much our entire society. So it's like just everything gets bigger. I mean, looked at other people. This is just our world. Everybody is bigger. Everything is bigger. So your cells grow too much, and it leads to mitochondrial dysfunction, necrosis, senescence. And the main thing, and this I've seen in studies, but this is also one of my theories, this is actually a loss of the dynamic balance that you need for mTOR. So you don't need it to be on and you don't need it to be off. You need it to be on when it's supposed to be on and off when it's supposed to be off. We're trying to rapamycin in treatments like that is mimic this, right? But what happens is we're all living in a chronic go, go, go world, and your mTOR1 is going all the time. And that is really the issue.
Gotcha. Okay.
Chronically activated, even you got stem cells you're producing or you get exogenously, they can't respond to the environment. Instead, you get more SAFs, more senescence, etc.
Makes sense. Okay.
And again, just a little summary here. So why is this important for aging? Because you're not having enough time for autophagy. You're not having time for the house cleaning of the cell and the renewal of your organelles and the renewal of your proteins. So, it's like your factories inside your cells are producing they're producing, it's like a cheap quality factory versus a high quality factory. Which products do you want inside your body? Of course, you want the high quality ones. Well, you don't get the high quality ones when you have high mTOR1 because you're not having the autophagy you need to keep the factory producing the right products inside your body, basically.
It's funny from a philosophical point of view, and as you're mentioning this, I think of the oceans filled with plastic and global warming and all those things, and I think what's happening inside our bodies is almost exactly what's happening on our planet, right? We've got this overproduction because we're living these big lives and we're producing so much rubbish and stuff. And so it's, I follow the Great Ocean Cleanup, and just some of the rivers and oceans, you see just so much plastic. It's really scary, but that's what's happening inside our bodies with all the consumption of sugar and seed oils and refined fatty acids and processed stuff. We just produce more and more garbage that our immune system can't clean up, and we're ending up global warming and producing all these plastics that are bugging up our system. It's almost the same thing, right?
Oh, exactly right. And, as within, so without. It's so interesting because, those same toxins out there, what's inside of us, creating more of the senescent cells that are, underlying all these disease processes. Yeah.
Yes, fascinating.
Super interesting. It really is. Really is. So, I had several aha moments when I was looking, when I was going.
I would have too. I'm having them myself looking at your presentation. I'm like, aha.
All right. Apologies for the slides here. Oh, yeah, here we go. So mTOR is implicated in the following diseases of aging, what does everybody have when they get older? It's on this list, Alzheimer's, heart disease, immune decline, chronic flus, colds, autoimmunity, cancer's on this list. Ultimately a lifespan reduction. Osteoporosis is on this list. I think I have a study about this. Sarcopenia is on this list, which is the frailty of old age. You have an old person, an elderly person with all of the hallmarks of aging, thin, frail, osteoporotic, no muscle mass. Their mTOR is overactive, and they're just stuck in this on position. They can't heal anything. Yeah. So you try treatment after treatment. You can take as many herbs as you want. You can take a lot of things, but unless you're really getting to the heart of some of these, the mTOR and or senescence pathway, you're probably not going to get a lot of headway. You really aren't.
No, it makes complete sense to me.
Yep. Oh, yeah. So here is, this is just about sarcopenia. This is a study. We don't need to go over this too much, but sarcopenia is a big issue when you get older, right? Your muscle mass, when you lose muscle mass and you get older, if you fall, your hip fracture rate's going to go up, you break ribs, and all of that just is going to lead to a really poor quality of life. And that happens with so many people. So my mom, as she gets older, I watch her. I'm like, okay, we got to work on this to keep that muscle mass up for her.
And I think they've done studies to show the more muscle mass you have, the slower you age.
Oh, okay, yeah, exactly. I call muscle it's like the currency of aging, really is.
Yep.
And again, you got to build it when you're young. So for all the listeners out there who are a little younger and still have muscle mass, you got to work out, keep that muscle mass up. Super duper important. Now we're getting to some of the study, but before we do that, maybe we just stop here for a second, see if you have any questions over what we just talked about there.
No, I find it really fascinating. And for anyone listening, what we're delving into is just the mechanism behind chronic disease. And we know kidney disease is most commonly caused by cardiovascular disease and diabetes, which are, hallmarks of this. And then we get those cells because the kidneys are filtering everything, right? And so those cells migrate, those senescent cells are migrating into the kidneys. And probably one of the major mechanisms, apart from high blood pressure damaging the small nephrons inside the kidneys and glucose making the blood, globular and thick, but it'll also be the transport of these senescent cells out of, say, things like the pancreas and out of the cardiovascular system. Because the kidneys are filtering everything, they're going to receive all of these cells. So you've got these senescent zombie cells implanting themselves in there, producing cytokines, driving inflammation. If you listen to anything that I produce, inflammation and oxidative damage are my precursors to fibrotic changes, which is what we try to prevent and reverse in chronic kidney disease to get kidney function back. So that is why this is so important.
And inflammation is from the cytokines. Oxidative damage drives senescence, drives these. So we're saying the same thing. So for listeners out there getting these new terms, and how does that relate to, the message you've been delivering to them? That's how it relates. And these chemicals that the senescent cells are producing, those work at a distance. So, not just local. They are chemicals, like you're saying, that will go through the bloodstream. So they have a long range effect, and of course your kidney's filtering those chemicals out in the liver. So of course the kidney and liver are going to be under a lot of stress when you have a lot of those, and they're going to be impacted very, very quickly with that. And that's probably why we're seeing so much kidney and liver disease in our world, right?
Yeah, I totally agree with you. And they can go together, so it's fascinating. All right. I think that's a great overview. So let's delve more into the treatment. We've talked about mTOR. So rapamycin, okay? How does it work?
Yeah, give me a second here. Let me, I think I got that here in these slides. Yeah, so here, can you see that? No, I didn't share the screen yet. Let me get that there. Okay.
Perfect. Yep, I can see that.
Again, rapamycin is the gold standard of longevity research. It shows increased longevity across all eukaryotic cell lines. That's where I was looking for earlier, because it's in all eukaryotic cells. It's FDA approved in the US for immune suppression and kidney transplant, for this rare type of lung disease here listed.
Which is, from my understanding, a fibrotic lung disease, isn't it?
Oh, okay. Yep, that makes perfect sense.
I think it's a fibrotic lung disease, is my understanding, which I found really fascinating when I was looking at that. Yeah.
Right. Yeah, and then there are rapalogs and analogs of rapamycin. Everolimus is another one that's FDA approved for tuberous sclerosis. Yeah. So again, it was FDA approved in the U.S. in 2009. Again, it's mostly used for kidney transplant to block kidney transplant rejection. The side effect profile is very low. And most of these people aren't just on rapamycin, they're also on a very high dose of prednisone and or 2 or 3 other drugs, and yet they still don't have a lot of side effects.
Yeah.
So we'll go through a little bit more side effects, but yeah, so there was one study showing people on rapamycin chronically have less skin cancer.
Fascinating.
Another one showing less kidney cancer. They did show a possible increase in prostate cancer. But again, those people are on a handful of meds, so hard to know.
Yeah.
Hard to tease that out. Yeah, so again, here's more of the rapamycin for lifespan extension. So in 2009 study, rapamycin showed increased lifespan of 20-month-old mice, and those are equivalent to a 65-year-old human. So the males live 9% longer and the females 13% longer. In 2014, they did it on mice that were the equivalent of 40-year-olds, and they found that the mice lived 23 to 26% longer, the male versus the female. So again, that's why you want to use it a little earlier in life. You don't want to wait till everything's fibrosed and senescent before you start rapamycin. Again, if you already have that and you are unfortunately already at that state where you have that sort of illness, of course you can still take it, and it will slow down the progression of it to something worse. But the sooner you can, the better.
Yeah.
Okay. And I've got, give me 1 second here.
Yeah.
A little out of order for this talk.
So let's go into using rapamycin. How would someone use this in, say, kidney disease or chronic cardiovascular disease or diabetes?
All right, or even better, a little younger before you get those. But of course,
that one too.
Most people aren't too excited about these topics until they have something. So
so true, so true.
I appreciate that. But tell your friends and neighbors and anybody willing to listen, please. We need to spread the word on these things. So dosing rapamycin. Here's the nice thing about it. You can dose it every 7 to 14 days. Most clinicians recommend every 7 days. And the dose for humans, 3 to 6 milligrams per dose. Where's that next slide I'm listening for? Okay, yeah. So here, the rapamycin, the half-life is 62 hours. That means every dose you take will stay in your body for about a week or longer. So that's why you have to dose it. And you don't want to block the mTOR2 because that's where all the side effects come from rapamycin. So you just want to block the mTOR1, and that's why you want to take the low dose of rapamycin. So if you take it daily, you're going to block mTOR 1 into mTOR 2, and that's where the more side effects come in.
That's definitely for me. So if everyone was listening at the beginning, I said I take it daily. I take it for an autoimmune disease. So I'd have to, for that autoimmune suppression, you are taking it daily, right? You don't get that same autoimmune suppressant effect with the weekly. And I wonder then, Dr. Camp, do you think then that autoimmune is part of the mTOR2 pathway that we just don't quite understand yet?
Good question. Yeah.
Don't know.
Yeah, very possibly. Yeah, very possibly. And it might also be that, these are questions we don't know, like, is it good to do a period like that where you take it more daily dose or more frequently? Well, let's cover these, and I'll tell you more how I've used it and how I use it in certain patients, because every doctor is different.
Okay.
But first, the side effects here, Fiona. So the side effects: dose-related canker sores. So those are the mouth sores. Probably most people have had them at some point in their life. Very painful. You notice them quickly. So this very dose-related. If you get it at if you get it at a certain dose, first off, don't take the next dose until they go away, of course. But once they're gone away, you probably want to lower the dose. So that's the most common one. And diarrhea and GI discomfort, they're related. Your mouth is your intestinal tract. So if you got sores in your mouth, they're throughout your whole intestinal tract. So your stomach's going to hurt too when you got those, for sure. And so you again, that's a good sign to lower the dose. At the higher doses, you are more likely to get upper respiratory tract infections and skin infections. And I noticed this when I was taking rapamycin. I've never had skin infections. I from the country, I got cuts a million times in my life, never even put anything on it, healed a few days later. Taking rapamycin, cut myself somehow in the trash can, which is not really a clean place to cut yourself, and that definitely got infected. So this definitely happens. The lung infections can be real. Dr. Green he prescribes on the higher dose, like he gives everybody 6 milligrams. He gives them also azithromycin just in case they get a lung infection or a cough. If they get a cough or a fever, he says just take the azithromycin, don't think twice. Okay. I have never seen a lung infection in my patients, but I'm dosing people a little lower. I typically dose people in the 3 to 4 milligrams a week range, because I have patients that are more sensitive and more prone to getting side effects because they're more sensitive. And I found the 3 or 4 milligrams to be a sweet spot where people are getting what feels to be long-term benefit without getting skin infections or lung infections or canker sores. I got the canker sores once when I was taking 6 milligrams consistently, and I was like, let's bring that dose down.
Yeah, that's definitely the side effect that I get. So, yeah.
And then, the question is, for next question would be, so how long do you take it? That's the question.
Yes.
So, what a lot of studies online are, and what Dr. Green are studying is once a week forever.
Right. Okay. It's a forever thing.
Just once a week forever. I don't know. I mean, I want to see those studies. I think, this is a little bit what we don't know, but I did find one study. Let me see if I can find a slide for that. I did one study from a big expert that I really thought was really interesting. Here we go. Let me go. I'll go. We've got 2 slides here for you. So first one here is, might just go over review my clinical guidelines. So again, I dose most of my patients in the 3 milligram range per week. And most of them already have low senescence and low inflammation. And when I'm trying to decide the dose, what I'm supposed to say, I look, do they have, first off, what's their age? Are they larger or smaller? Small elderly patients, 2 or 3 milligrams. That's really all they need. Younger, bigger men, lots of muscle mass. Maybe I'll give them higher. A little higher. Those are the 6 milligram patients.
Gotcha.
But this is the one I really wanted to show. So I saw a study and from Dr. Brian Kennedy. he was formerly at the Buck Institute, and that's where FOXO4-DRI, I believe, was discovered, interestingly.
Yes.
I think this guy was one of the guys discovering. So this guy is genius. He now works at Singapore, and they have a university. They have a whole program on anti-aging and senescence, and this guy's, I think, brilliant. He, in one of his papers, he proposes that the improvement that we're getting from rapamycin aging is due to the improved dynamic range of the mTOR. So again, what we were discussing earlier, it's not like you just have to cut it off and cut it on. It's like what your body should be able to naturally hit the gas and hit the brakes when needed. So the reason I'm bringing this up is because my studies here suggest that even short courses of rapamycin might have long-term benefits. So who the heck knows? I mean, I only did a 3 or 4 month session of rapamycin 2 years ago, and I haven't taken it since. After reading this, and I'm not sure. I might take another course here soon, but it is possible in certain people that you might get long-term benefit with just a few month course if this mTOR starts working like it's supposed to work.
So it's almost like for some people that probably don't have chronic disease and things like that, it's almost like a Control-Alt-Delete reset of the dynamic pathways of mTOR.
That's exactly how I was thinking of it, and as I've gotten more experience in my career, I've come to appreciate that most people don't need anything forever. I don't like ever saying, "Oh, take that forever," and I'm very careful with that because I told people years ago, yeah, take those supplements, and then years later they call me back like, should I still be taking those? I'm like, oh no, that was just for a few months. So now I try to adjust everything, for what people need in that time. So, and these are the questions we don't know. It's like, does that work? And who's that work on? I mean, I think the side effect profile is so low, taking it for the long term is not going to hurt most people. Yeah, I really do. I think that's really clear in the evidence. And again, Dr. Alan Green has a study he published a few years ago where they looked at the side effect profile, I think of around 300 people or so. And side effects were minimal canker sores, diarrhea, stomach upset. And again, those are most people in the 6 milligram a day dose. If you bring that down, then that side effect profile goes down even further.
Okay. Yeah. So we've gone right over rapamycin. Now, for people listening, how easy is it to get that prescribed? It's obviously prescription-only drug, or can people buy it off the shelf over the counter?
It's prescription only. I haven't answered that question in a while, but I know 6 or 12 months ago, there was an online group who were looking for study volunteers, and they gave you a prescription for rapamycin to be part of their study.
Right.
I don't even know if it was for free. It might even been for free. It might even they had somebody who was paying for it. But that is out there. There are people doing that. And if not, there are, of course, pharmacies that, do prescribe things. With or without doctors' prescriptions out there, but for most people, I think it's relatively safe. There are more and more doctors doing this now, so a lot of doctors are doing it. I mean, I've had neighbors who've come up to me and said, who are ER doctors, and I told them a little bit about when they go, "Oh, do you take rapamycin?" So a lot of doctors are using this and know about it. They might not tell anybody, so a lot of doctors will take things themselves years before they ever prescribe it for a patient, or they'll give it to their family members. But you can always ask your doctor, especially if you have a holistic-minded doctor, if they know about it and if they're willing to prescribe it. And you might be surprised. Sometimes they might be willing to, because again, it is FDA approved, has a very low side effect profile. So, a lot of doctors are using this now. Yeah.
And let's dive into, unless there's something else you want to talk about rapamycin, are there, for people that are like, what, I'm not sure, even though it like you say, it's a component of soil that works as an antifungal, and then drug companies have just got their hands on it and turned it into a drug. I know my doctor was very happy to prescribe it once I showed him the studies particular to MS, but are there any natural alternatives that work as senolytics that do the same sort of thing that you could recommend for people that just either can't get someone to prescribe rapamycin, or for people that think they want to try a more natural version, and are they as effective?
Okay, yeah. I'd like to correct one thing you said. Rapamycin is not a senolytic, it's a senomorphic. So it will not
Right.
kill senescent cells. It will lower their production. And that there are senolytic drugs and senolytic supplements. Yeah, those are separate. Rapamycin, again, lowers the production of them. Yes, there are other senomorphics. The most famous one is metformin. That is also a prescription. So that's one of the ways it works, and a lot of doctors have been using that for longevity for many years, and that's one of the ways it works. It actually works as a lowering of senescent cells.
It's not as effective in the longevity game as rapamycin is it? No.
Oh, yeah. Again, we don't have clear answers to that, but likely not. Yeah,
Okay.
likely not. The main thing that helps with the cheap version, if you want the cheapest version that requires no prescription, it's called lowering your caloric intake, right? So fasting and intermittent fasting and caloric restriction, yes, that absolutely is the best way to mitigate all diseases, right? We know that. And also, I mean, the science here clearly shows the how and why it works.
Yeah, that's very good. And so back to your correction of what I said, which is brilliant. I'm glad you did that. Why would you not use then a senolytic versus a senomorphic that's mopping versus, so my understanding is a senolytic completely can mop up and clear those cells out. So why would we not just use those? Why would we use a senomorphic like rapamycin versus, say, dasatinib, which is a complete senolytic?
Yeah, that good question. In my practice, I mostly use senolytics. Again, I'll give people senomorphics like metformin and rapamycin for a period of time. And what I think that idea in mind to increase that dynamic range of the mTOR so it's working again properly. Then I use senolytics more for treating the inflammation, treating the cytokines, treating the disease caused by the senescent cells. Yeah.
Okay.
So that's exactly how I think about it. So everybody would probably benefit from, a round or 2 or 3 or 4 months of rapamycin. The question is, do you need to do it forever or not? And would senolytics also help you? I think there's probably an argument to be made to use both. I wouldn't recommend at the same time. You always got to think about drug interactions and these sorts of things. I would not. And actually, let me correct this. You would definitely not use them at the same time, and you want to use the senolytics first. Why is that? Because the senolytics, like dasatinib, actually work using the SASP. So they use the cytokines against the senescent. So they take the zombie's weapon and make it shoot itself. So if you take the weapon away from the zombie, then using the rapamycin, then you got less weapons to kill them with. So the theory is you should use the senolytic first if you're going to use senolytic. So that's, I learned them in a different order. I learned the rapamycin before the senolytics. So most of myself and many of my patients, I did them in the opposite order. But now when I look at patients and want to recommend it, if they have a high senescent burden, that I surmise via high inflammatory markers, high inflammatory illnesses, I will give them the senolytics first, followed by rapamycin.
Makes complete sense. And do you want to, I know we've done a bit of a talk before about some of the senolytics. Do you want to talk about them? Should we leave them to another podcast? What do you think is best?
Yeah, sure. Yeah, we can. There's one prescription, the main prescription that's been discovered and looked at in studies is dasatinib, mostly used with quercetin. So dasatinib with quercetin. Foxo4-DRI is another one that's an injectable peptide. And then the third class are just like the plant-based ones. So fisetin, quercetin, and there's several others, but those are the two that have been researched the most and seem to be working the best.
Yeah.
I've used a lot of Foxo4-DRI and I've used a lot of dasatinib. I mostly use the dasatinib with quercetin now just because even though it's expensive, it's a lot less expensive than the Foxo4-DRI. And the Foxo4-DRI does burn when you inject it. The good thing about senolytics is it's also like the rapamycin. You don't have to take them you just take them on a hit and run basis, meaning you take them for like either you can take them once a month, once every 2 months, or twice a month. And there's no real consensus on that. I think Dr. Green takes dasatinib with fisetin every 2 weeks.
Right.
I take dasatinib with quercetin. I was taking it monthly. I now take it weekly, but that's because it also works on mast cell activation. So I'm using it for a different reason. I don't want to confuse people. I use it a little more frequently for a different reason. If I'm just using it as a senolytic, I usually recommend it every 2 or 4 weeks for 2 doses.
Yeah. That's my understanding of it too.
Or you could say 2 doses a month. I think what Dr. Green does is 2 doses a month, and you can take one every 2. You could do every 2 weeks, 1 dose, or just wait and take two together once a month.
Mm-hmm.
In preparation for this, I was looking at dasatinib with kidney disease, and I did discover when you take dasatinib for daily treatment for lymphoma, for which it's FDA approved, there is a 10% risk of kidney disease.
Right.
So I would be hesitant to recommend it for people with kidney disease without more experience. You definitely want to be under the experience of a doctor who's checking your EGFR and creatinine levels and monitoring your kidney function to make sure you're not going to get worse. Now, when dasatinib is used as a senolytic, the dosing I use is much lower than they're using for lymphoma patients. So, and also, again, you're using it once a month versus daily. So I haven't seen in any of the studies when they're looking at dasatinib as a senolytic, I haven't seen any studies pointing to any kidney disease.
Right.
Those studies are out there now, so I did just want to mention that. Yeah.
Perfect. So if people are a bit nervous, maybe they could look at using FOXO4 DRI instead as a peptide.
Yep, the FOXO4 DRI is likely even better than the dasatinib with quercetin, especially for cancer, for senescent cells leading to cancer. This is based on, we don't have studies on that. This is just speculation based on how it's working, because FOXO4 DRI is working on the p53 pathway, which is one of the main pathways for apoptosis, which is programmed cell death. So when you don't have programmed cell death, you get cancer. So one of the ways FOXO4 DRI works is to get the senescent cells to kill themselves, basically.
Yeah.
Yeah.
And FOXO4, I mean, for people listening, FOXO4 is what I use, and it's great because I think their peptide dosing guys recommend you take 1 course every 6 months, and it's a 3-day course, 3 milligrams. You inject on a Monday, Wednesday, and a Friday, and you're done. For people with chronic kidney disease or someone like myself, I use it every 2 to 3 months because I'm trying to use it more as a mop-up and a preventative, and then I'm using rapamycin on top of that. But I just had a patient who had COVID, has MS, and is about to start rapamycin. We did a course of FOXO4 DRI right before it, and she just said normally after COVID she feels foggy-brained and gets that real post-cytokine sort of stuff, and she just said had none of it. So I was like, good old FOXO4 seemed to have mopped it all up, so that was great.
Yep. So that cytokine storm from the flu, from COVID, from other viruses is related to senescent cells. So, Dr. Green noticed in his study of that, in the study they had of people taking rapamycin, if they got COVID while taking it, none of the people in the study got severe COVID or long COVID. So there's clearly a correlation there, and so I took that. And so I've actually, when I've gotten colds, flus, or COVID, I've been taking dasatinib, and it has cleared up the mental side effects, the brain fog, etc., caused by those cytokines really immediately.
Amazing.
I don't know. Yeah, and I don't know if there's research on this with dasatinib as an antiviral or not, but I don't know if it's working as antiviral or if it's just blocking the senescent cell. But what most people don't know is almost all the drugs have. We know almost all these drugs are doing so much more than is studied or we know about. They all have a lot of different effects on so many different cell types, and we're only researching like one tiny fraction of it.
Yeah.
Yeah, so, the other interesting thing, which I mentioned earlier, is that I discovered this recently. Dasatinib lowers the it lowers the production of your mast cells. So for people with mast cell activation syndrome and mast cell disease, dasatinib is very useful because it actually lowers the production of those mast cells, and it's probably there is some research on this. I don't think there's a lot, but I think also these mast cells are becoming senescent. I think that's what's part of the issue with a lot of people with chronic disease. They're getting senescent mast cells, creating the worst cytokines you can imagine, all these histamines and other cytokines that you just make you feel brain fog, tired, anxious, and have insomnia, which is just...
Yeah. I totally think that theory is correct. So, yeah, that's what we're seeing in long COVID, right?
Yep, absolutely. Yeah, so I use all these for people with long COVID, and I can't say my success rate is perfect, but the patients that have followed up with me consistently, 90 to 95% of them are back to normal.
Well, that's an amazing stat for long COVID.
Yeah. Yeah, exactly. Yeah. In the ones who didn't, the very few, it's because they have either mold in their house or Lyme disease. Yeah.
Right. Fascinating. Yeah. Oh, I find all of this fascinating, Dr. Kemp. Is there anything else you want to add about rapamycin, longevity, kidney disease, and things like senolytics?
Oh, yeah. We can end. I've got a summary slide here. Yeah, so we'll end with a little summary of everything we talked about here, because there was a lot. So again, how does rapamycin work? So here we go. Review of how rapamycin works and the evidence of potential to extend human lifespan. So rapamycin suppresses this process called geroconversion, which is the conversion of normal cells to those senescent cells. And geroconversion is basically aging. We can just call it aging. So rapamycin suppresses that geroconversion through the inhibition of that molecular pathway called mTORC1, or mTOR1 for short. This only happens at low dose and infrequent dosing of rapamycin. Remember, it has a long half-life, so we don't need to take it but once a week or once every 2 weeks. All models clearly show that the processes that inhibit the mTOR1 pathway extend lifespan in diverse species from yeast to mammals. Rapamycin extends lifespan in all species tested, from yeast to mice to worms. Dog and human studies are in progress now. The only other solution besides rapamycin that does the same thing is caloric restriction. And we know in almost all studies that caloric restriction extends lifespan.
Yeah, and it's fascinating, the studies that what's his name, Longano's, the Italian guy that's doing in these kind of caloric restriction and using things like MS and other autoimmune diseases is just amazing what it's doing at resetting the system. And I'm a big fan of caloric restriction and intermittent fasting. I think that's something everybody should be doing at least once a week, once a fortnight.
Absolutely. I think that's it, Fiona. Yeah, I mean, I just finished a little fasting and retreat, and I used to, when I was younger, I would fast, 3 or 4 day fast, and not just water fast, just drastic caloric restriction with a very simple, low inflammatory diet, maybe 800 calories a day, something like that. And I did that, 3 or 4 days every 3 months. When I was doing that younger, I had no problems ever. And of course, then you become busier in life, take on more responsibility, and you forget about those little basic things, which are proven to really help so much,
Yeah, and it's like you say, it's the cheapest and most effective way of doing it. Walter Longaro, I think is his name. Okay. He's the Italian researcher on intermittent fasting and has a lot of stuff. He has the Prolong diets.
And with food costing as much as it is now, you save. Save a little bit when you go fasting.
Exactly. Cost of living is a great way to keep your cost of living down. Do some intermittent fasting 2 times a week. Your body will thank you. Well, Dr. Camp, I always appreciate your expertise and time and spending time to chat to our audience. I know they love your wisdom and what you have to share. And I think this is such an amazing topic and an amazing thing for people to go and talk to their GPs about and have a think about ways that they can decrease their senescent load. And, and as we were mentioning, if you are a bit younger and you're the daughter or a friend of someone with chronic kidney disease, that this, when you're in your 40s, looking at doing something like this and putting the dynamic adaptability back in the mTOR pathway might be something that everybody would benefit from. If people want to get a hold of Dr. Camp, or if they want to work with him, are you still taking new patients? I know how incredibly busy you get.
Yeah, we're always, it's always ebbs and flows a bit, we have a waiting list now, but, sometimes we get super excited. I love, interesting Sherlock Holmes cases sort of a bit, so, sometimes even if we have a waiting list, somebody will pique our interest in, I can more time, just because it keeps me entertained. Not entertained, that's not the right word. It keeps me motivated to learn more when I get certain cases. And, all of this, the reason most doctors don't know about this for our audience is I have to spend hours a day. This is not like, for every, I was calculating this, for every 1 hour patient contact I have, I probably have research 4 hours. For the average doctor, it's probably 100 patient hours for 1 hour research.
Couldn't agree more. And it's,
and so that's, and I'm just lucky enough to have the patients that in the practice style and in the whole model where I can do it just like you do, where we can actually take the time and research and dive into this. And so, again, there's certain cases that'll lead me down a path of learning something new and exploring new concepts or new application for something I've learned before. So that's the long answer to your question, Fiona.
No, it's a good answer. Your brain and my brain's wired exactly the same way. It's why I take the cases that nobody else wants, because I enjoy them and the research and because it leads to something else about that I can use in myself or whatever that is. So I'll put your website details below. If you Google Dr. Morgan Camp, his details will come up, and his actual website where you can contact him is drmorgancamp.com. If you go onto the website there, there's an intake form and you can do a concierge service through there and give him a contact. Dr. Camp, thank you again. Remember to hit like and subscribe. That way you'll get notified anytime we put up new videos. If there's any content that you would like Dr. Camp to talk about, please put in the comments below, and I'm sure I can wrangle him back into doing another podcast for us. And remember to head to our website, www.kidneycoach.com, to find out more about what we do. In the meantime, thank you for being part of our community, and we look forward to seeing you next time. Thanks again, Dr. Camp. Really appreciate you.
Thank you.
Bye.